All right. Just wait a second or two and we'll get going. You guys know if Molly is joining us today?
She's on vacation.
Vacation, yeah.
Okay, well then I guess we're good. Okay, so it's going to be a somewhat brief one today, but I wanted to, we had done some drugs in the past and we haven't done one in a while, so I thought we would do an important one today, which is amiodarone. So amiodarone, as you know, is a class 3 agent, and class 3 agents prolong the action potential plateau with a very minimal effect on phase 0 of depolarization. And we see here in this nice little diagram from old textbook, Natus's Pediatric Cardiology, that the action potential is advanced outward through phases 1, 2, and 3, so that it's longer, and the impact on the ECG is a very minimal widening of the QRS, but importantly, widening in the QT interval. And that's really the one of interest when we're clinically monitoring somebody who is on amiodarone. Unlike all other agents, the effects are felt at all levels of the heart. So most arrhythmia medicines have much more effect on one part or the other. Amio can affect everything. So it can prolong the action potential in atrial muscle, ventricular muscle, Purkinje fibers, and even in accessory pathways. It also has direct effects on the SA and AV nodes, reducing sinus node automaticity and slowing AV nodal conduction. And again, as we talked about, it has, according to Dr. Walsh in his chapter, it has widespread changes on the ECG that can be characterized by sinus node slowing, prolongation in the PR interval, because as I said, it affects all areas of the heart, slight increase in the QRS width, but most importantly and most dangerously, potentially, QT prolongation. Of course, QT prolongation, or enhancing, lengthening repolarization, is one of the key ways in which it works. But as in most things, everything in moderation, a little bit is good, a lot is not. So clinically, we use amio for multiple things: VT, postoperative jet, SVT. One of the important aspects about amiodarone is that it has alpha blocking properties, which causes vasodilation and afterload reduction. And that may be why it generally is acceptable for patients who have poor function. In fact, when it was first introduced, I believe it was initially not actually known to be an antiarrhythmic agent. I think it was introduced initially, or at least developed, as an afterload reducing agent. And it was only after it was clinically used that it was determined that its most potent effect was as an antiarrhythmic agent, but it does cause vasodilation and afterload reduction. It is a very potent negative inotrope in experimental studies. That's important because, sometimes people say, oh, we can give amio because it doesn't affect function. It actually can affect function, particularly IV amio. And there's a lovely paper by Lizzie DeWitt from Boston Children's. I reviewed it in the podcast like maybe 4 years ago. It's a very good episode in which she describes her animal experiments, or I should say bench research, showing very clearly that amio is probably the biggest negative inotrope of all the major IV antiarrhythmic agents, but probably because it causes some afterload reduction, and if given slowly enough, it's generally well tolerated. It comes in oral and IV forms. For oral loading, I'll remind that for SVT, the dose for loading is 10 per kilo per day, typically over 1 to 2 weeks. And then chronic dose would be 5 per kilo per day. We're going to get into side effects in a moment, but because of side effects, generally speaking, you always want to try to get away with as little amiodarone as possible to treat the arrhythmia. So although 5 per kilo per day is the general recommendation, it can be given even at a lower dose. And for VT, the loading dose is typically 20 milligrams per kilo per day, typically again over 1 to 2 weeks, followed by 10 milligrams per kilogram per day as a chronic dose. Sometimes we'll go down on that as well, again, on the theory that less amiodarone is better. The reason, of course, that we give so much of the medication, literally double the normal dose or the chronic dose for both SVT and VT, is because of the half-life of the agent, which is very long. The half-life of amiodarone, depending on your age, can be anywhere between 3 and 6 weeks. So I believe it's thought to be one of the agents with the very longest half-life, and so you have to load for a long time, and it's not uncommon that you may even need to load longer than 1 to 2 weeks. For IV loading of amiodarone, for things like JET or SVT, the classic recommendation is to give 5 milligrams per kilogram of body weight over 20 to 120 minutes. If you look at PALS, they'll say to give it over 20 minutes. As you've probably noticed, we virtually never give it that fast. If somebody is arresting, yes, you should do it that fast. Otherwise, because of the possibility of hypotension, we typically give it slower, usually over 1 to 2 hours. And actually, some intensivists like to give it in little aliquots of 1 per kilo, waiting until they see effect and then stopping. For example, Tony Rossi in Miami often tells me that he gives 1 or 2 per kilo, and oftentimes, particularly for treating JET, he claims that if that's enough. It's not been my experience, but I trust he's obviously got a lot of experience. For VT, again, you would give 5 per kilo over 20 to 120 minutes, followed by, actually, that's wrong. It's not 10 per kilo per day. It's really 20 per kilo per day. And importantly, because the half-life of IV amiodarone is much shorter than oral amiodarone, you need to overlap the IV and the PO load at the same time when you're transitioning to PO. So when a patient is more stable and you're thinking about switching them to oral amio, you typically would like at least 2 or 3 days of the IV and the PO overlapping. I have had the experience more than once of just stopping IV amio and switching to PO and having an arrhythmia recur temporarily. So very important. This is something that actually our adult colleagues discovered a long time ago, and we've now adapted in peds. There are a number of serious side effects associated with amio. We've talked about this many, many times, particularly with small infants. The most dreaded one is hypotension and so-called cardiovascular collapse, which is seen in between 1% and 5% of small infants who get amiodarone. It's thought to be due to the alcohol component of the formulation, which is something called tween 80. And so, again, it's very important to monitor patients very carefully, and at the first sign of a problem to stop it. But oftentimes this cardiovascular collapse is very serious and can result in a need for support such as ECMO. Very importantly, amiodarone causes very bad phlebitis IV and can result in chemical burns. So if you're giving amiodarone peripherally, one needs to be very vigilant at looking at the IV site constantly. And my recommendation strongly is that once a patient is stable, that central venous access be obtained to give amio, because of the very significant risk for chemical burns associated with its use. I've seen it many times, and it is remarkable how reliable it is that if you've saved somebody's life with a terrible arrhythmia and they're left with a very small chemical burn on their hand or arm, that is all that the family cares about. So very, very important. Obviously, we don't want to cause chemical burns in anybody. So make sure the IV you're using is effective and works, and try to move it centrally as soon as you can. Whole series of complications associated with amiodarone. Thankfully, most of them are either not important or only associated with chronic usage. Proarrhythmia. Interesting, all arrhythmia agents have potential for proarrhythmia, but one of the nice things about amiodarone is that it actually has a very low incidence of proarrhythmia. Now, if you give amiodarone to someone who already has a long QT interval, that could be very, very dangerous. But in an otherwise healthy, normal patient, one of the big benefits of amio is it is rare to have proarrhythmia. This is in contradistinction to things like flecainide or disopyramide or propafenone, which or even sotalol, which have a much higher incidence of proarrhythmia. Corneal microdeposits are commonly seen in patients with amio. Something like 95% of patients who get amiodarone develop corneal microdeposits. It is extremely rare, however, that those microdeposits have any actual impact on vision. That said, there are rare times when it can cause retinal issues, and so it is formally recommended that patients be seen by ophthalmology. But oftentimes we skip that because the expectation is a patient will not be on amiodarone for very long. And the corneal microdeposits don't typically have an effect on vision, and I believe that they resolve when you've been off the agent for a while. Thyroid dysfunction is quite common in patients with amiodarone, whether it's hyper or hypothyroidism. So that's something that needs to be monitored carefully in every patient who's on amiodarone. Pulmonary interstitial fibrosis. This is virtually universal in people who get amio, but only after many, many years, usually, of amio. And typically it's a complication you see in someone who's been on it 5 or 10 years. So this is probably the single most important reason why we don't generally like people on amiodarone chronically, because of the concern of this. Because once you develop this complication, unfortunately, stopping the agent will not reverse the degree of fibrosis that you've developed. And so it's very important that anybody who's on amiodarone for any chronic period of time have pulmonary consultation with formal PFTs or assessments to make sure that the patient is not developing this. Chemical hepatitis as a result of amio is also sometimes seen, and this is one of the reasons why LFTs are very important in patients on amiodarone. Peripheral neuropathies are apparently very common in patients with amiodarone. They're typically not very functionally problematic, but they can be. And so one needs to be very vigilant in asking if patients are having any kind of neuropathic symptoms. Photosensitivity of the skin. This is very important. Patients are very sensitive to development of skin burns as a result of sun exposure. And so any patient who's put on amiodarone or who's on it chronically needs to be reminded, particularly in the summer, to use aggressive sunscreen protection because this is a very, potentially very debilitating problem. And finally, amiodarone can cause a bluish tinge to the skin. So this patients need to be sort of made aware of this. I'll be honest in saying I'm not sure I've ever seen that, but that may be because I'm not looking carefully enough, or potentially because it's only seen with more chronic usage. This is very important, the drug interactions, and I can virtually guarantee you that you will receive a question on your board examination on this topic, which is which drugs need to be adjusted when you're on amiodarone. So I remind that amiodarone is a cytochrome P450 inhibitor, and it reduces warfarin clearance, and it can lengthen the INR if you're on warfarin with amiodarone. And so one needs to adjust one's warfarin dose when you're on amio. It can also enhance digoxin levels. It can actually double digoxin levels. And so it's typical. So when you're starting somebody on amio who's already on warfarin, you want to monitor the INR very carefully, and you probably want to prophylactically reduce the dose by at least a third, and then monitor the INR. You may find you may need to even go further. You want to check the digoxin level. You want to actually just generally, we give about half of the usual dose of digoxin when someone's on it. And this is a sort of an issue that sometimes comes up where people, will see a patient on amio and dig, and they'll say, why is he on that little bit of digoxin? And you have to always remind the person that they are effectively on the right dose of digoxin. It just has to be downward adjusted because the level will rise in the setting of amiodarone. And other agents that can prolong the QT interval should be carefully vetted before you use amiodarone. So if a patient is already on an agent that prolongs the QT, you're going to really need to keep very close tabs on the QT interval when you give amio, because as we've discussed already, amiodarone routinely and regularly increases the QT interval. That's in fact how it works. But if somebody's already got a QT that's a little long because of an agent that they're on, you have to be careful about that. One of the more common interactions we see in the ICU is when patients are on methadone and are also on amiodarone. That combination can result in a long QT interval. There are multiple interactions with other antiarrhythmic agents. So very importantly, quinidine, procainamide, phenytoin, and flecainide levels all are increased with amiodarone, and all should be lowered when using with amio. So you've seen occasionally at our center, we have a lot of patients, right, who sometimes have very bad atrial arrhythmias, particularly infants. It's not uncommon that they end up on a combination of amiodarone and flecainide. And so it's very routine that you'll see that we're on a very hefty dose of amio and a very, very small dose of flecainide. That's because the expectation is that the flecainide, a very little bit is needed in the setting of amiodarone. And the agent can also potentiate beta blockers and calcium channel blockers. When amiodarone sort of first came out, there were lots of ads for it. And one of the ads used to say something like, the only antiarrhythmic agent with all four von Williams categorization effects. And so, as you know, beta blockers and calcium channel blockers are two types of von Williams effects. And so amio causes a lot of the effects of both of those agents. And so need to be careful when you're combining them. Doesn't mean you can't combine them, but sometimes you have to lower the doses of those agents because patients are too bradycardic, or they may have some heart block associated with amiodarone. And but this slide is very important because there's a virtual guarantee that this will come up clinically in your practice, but will also potentially be quizzed on an exam at some point. Does anybody have any questions about amio before we move on?
Yes, Dr. Pass, for the overlap, the minimum is going to be 2 days between the PO and IV, right?
I would generally say yes. That's what I would normally do. Now, there's going to be circumstances, the IV comes out, the central line needs to come out, whatever. But I would say, yeah, that probably is a reasonable thing to do.
Thank you.
Yeah. Okay. Let's move on to some unknowns. Okay. This comes from an ECG website called ECG Rhythms. So what is this diagnosis? And why don't we ask, let's see who we got here today. Who's on our list? Why don't we ask Ali? Ali, what do you think we're looking at here?
Good morning. Good morning.
Good morning.
So I see here that the heart rate is slow.
How
1,
slow?
2, 3, 4, 5. I think it's around 50, maybe.
Mm-hmm.
And when I look at the P wave, I see that the P wave in 1 and where's EVF? I'm looking.
F is on the very bottom.
Oh, okay. Yeah. So it's sinus, but I see that the PR interval is definitely prolonged. So I think it's first degree heart block, given that I see P waves before every QRS, but it's definitely prolonged.
But are there QRSs after every P wave?
Uh,
I'm going to point you
Yeah.
to this lead AVR.
Oh, okay. Yeah. This one. So yeah. So I think in this one I see here there's a beat in the middle. I think there's a P wave, like maybe right after the T.
Mm-hmm.
So maybe it's not. Let me see.
So are all the P waves being conducted?
No. So this one, like the ones on T are not conducted. So maybe it's in this case it would be complete heart block.
Well, no, it's so if we look here in lead 2, we see P wave is conducted, then there seems to be a P wave on the T wave, though it would be hard to tell in that one. Then P wave's conducted. This one is a little more obvious, right? That there seems to be a P wave afterwards. Then a P wave that is conducted, it seems to be, and then P wave after the T wave, and so on and so forth. So this is actually 2-to-1 conduction.
Oh, okay.
Okay, and so and this is sort of, we talk about what types of second-degree heart block are there. So there is Mobitz I, where we see progressive prolongation in the PR interval followed by a drop. And generally speaking, Mobitz I is thought to be suprahiscient or at the level of the AV node. And then we have Mobitz II, which is usually His-Purkinje disease, where sometimes all of a sudden you see a P wave that just doesn't conduct when you have normal conduction otherwise. And then there's this thing that we're looking at here, which is 2-to-1 heart block. And so 2-to-1 heart block is really either Mobitz I or Mobitz II. But it's hard to tell because we don't have a His catheter in place, so we don't really know where the level of block is. Now, people sometimes look at the PR interval and will impute or infer something about whether it's at the AV node or the whether it's Mobitz I or Mobitz II, but I think it would be sort of more correct to just say that we can't tell. So we would just call this 2-to-1 heart block, but it is a form of second-degree block. Now, it could be complete heart block, and you would need to see a long strip of it, but in other words, the P wave could be at exactly twice the rate of the ventricular rate, but the key here is that the PR interval is not changing, meaning that every other P wave does seem to be conducting. It would be a little strange if these PRs are precisely the same on all of the beats. So that would argue against this being complete heart block with so-called isosynchronous beating of the atrium and the ventricle. If that were the case, when we watch the strip over time, we would slowly see dissociation between the atrium and the ventricle in terms of depolarization. But in this case, because we have a pretty consistent PR interval, we would say that this is 2-to-1 conduction or second degree 2-to-1. Okay. All right, let's move forward. All right, this patient has intermittent fainting, and I'm going to ask Dr. Barris if he has any thoughts on what we're looking at here in terms of what this is.
All right, so this looks irregular. It also looks like our QRS is wide. How old is the patient?
I don't know, 54.
54.
1 year younger than the director of this meeting.
So now I'm just looking at the relationship between our P wave and QRSs, which look wide. Let's look at the strip on the bottom, even though it's AVF, but I think the P waves are fairly clear. So I think we can see that there's conduction in that string of, I think if there's conduction of that string of 3 beats. And then we have at least a drop beat. We have a P wave that doesn't look like it conducts. And then it looks like we have conduction. So maybe it's like a first degree heart block that then is second degree because we have a completely dropped beat. And then we also have a wide complex QRS.
Okay, I agree with that, but can you be more specific regarding the form of second degree block that we see? And just as a sort of nomenclature, I agree with you. It does certainly look like first degree block and then some second degree, but generally speaking, when you're describing a tracing, you sort of refer to the degree of block as you define it as the highest degree of block that you're seeing. So you would say there's some kind of second degree block on this strip.
So
we know
the
it's not, we
question
know
is-
we know it's not complete, right? Because some of the beats are absolutely conducting, just as you said correctly. So do you have any thoughts on whether this is
Yeah, is it
Mobitz
Mobitz
1
one
or
or
Mobitz 2?
two? So I'm just, again, I'm looking at that lead AVF again, just because the P waves are so clear, and I'm trying to figure out exactly if the PR interval is increasing. So just looking at that that second beat on the strip there, where we can see the P wave, I would say it's maybe 6 small boxes, and then the next one maybe I guess it's still 6, and then pretty close. It's pretty close. I would say it's Mobitz type 1, though. Maybe it's getting a little bit longer, and then the dropped beat.
Yeah, I actually agree with you, David. I think this is Mobitz 1. It's interesting. On this website, they offer this as an example of Mobitz 2 block. But I think I don't think they're right, actually, because I agree with you. I think if this is where, unfortunately, doing this on Zoom isn't as good as doing it in person if we had calipers. But I agree. I think that there is a subtle lengthening in the PR interval. I think this PR is, to me, looks a little bit longer, say, than this PR. So I would call this Mobitz 1. And, when I see a single non-conducted P wave on a Holter or a Zio, I typically will suggest that it is Mobitz 1. I don't like to give someone a diagnosis of Mobitz 2 when I only see a single non-conducted P wave. Because obviously, as we've discussed many times, Mobitz 2 carries a lot more implications in regards to diagnosis and potential need for intervention than Mobitz 1. And so I kind of feel like I'd like to see a little higher degree of block before I label someone as a Mobitz 2. And I think in this case, there is a subtle prolongation in the PR interval, and I would say that it is more likely that this is Mobitz 1 than Mobitz 2. Now, this is a tracing obtained in the emergency room, and the patient is having intermittent fainting. So what would you do about this? Would you do any kind of workup on this patient?
We can look at Lyme we're not going to get back anytime soon,
Right.
but we can look at thyroid function.
Mhm.
We would do an echocardiogram to make sure that their function's okay.
Why you care about their function? What functional issue would you be concerned about? I assume you mean bad function. So what kind of bad function could be associated with heart block?
Like myocarditis or
Yeah.
MISC.
Right, could be one of those bad things.
Inflammatory markers would be, I
Right,
guess.
absolutely. You'd want to do that, looking for endocarditis or myocarditis, certainly. All great ideas. And then I think you would you would do all of those things and hopefully identify something that's causing this. This would be unusual but not horrendous in someone who's sleeping, but in somebody who's awake, this would be worrisome. And if all of those things came back negative, which, by the way, I've never seen this with everything being negative. This is, although this could be the case after you've had like a heart attack and you have some injury to your AV node, but I think if all of this is happening, basically you would probably need a pacemaker. This might be one of those rare indications for a symptomatic person with Mobitz 1 that might be a sort of a 2B indication, something that some people do and some don't. But it's an interesting tracing nonetheless. All right, I think with that, we'll stop. You guys like when I do the drugs, right? Review the agents. Is that right? I can do some more.
Yeah, I
that's
think it's
helpful.
nice to sprinkle that in.
Yeah, okay. All right, well, I appreciate your time and hope everybody has a wonderful day.
Thank you, Dr. Bass.
Thanks, guys.
Thank you.
Be well.